This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222. Hi there, it's Professor Michael Chapman. I'm the Medical Director at Life Fertility Clinic, Sydney. Tonight I'd like to start off by talking about endometriosis. The media coverage of endometriosis over the last 12 to 18 months has been quite significant, as women have come forward and told their stories about the pain that they have suffered and the ordeal they've gone through in attempting to sort that out. The problem with endometriosis is that once you have it, it's actually very difficult to get rid of. What is it? Well, basically the cells that line the uterus and the womb and that come away every month when you have menstruation, those cells, instead of being inside the uterus, for reasons that we still don't understand, end up attaching themselves to the lining inside your abdominal cavity, usually around the ovaries or behind the uterus. And those deposits go through the same hormonal changes that your lining itself does, and so once a month you get some bleeding, and not surprisingly, bleeding inside the tummy causes pain. The other pain that can happen is that if the deposit of endometriosis lands on a nerve, then that nerve can produce constant pain. They're the most difficult patients to treat, in fact. But let's look at endometriosis and infertility. So, of all infertile women, as it turns out, the data suggests that 15% at least will have, and maybe up to 30% in some studies, will have endometriosis as a contributing factor to their infertility. It may not be the only factor, but it's certainly something that we always go looking for. We start looking by taking a good history. Endometriosis pain is slightly different from normal period pain, and it generally starts sooner and often goes on longer than a normal, what's called dysmenorrhea, the pain that you had when you were a teenager, when you had a period, and some women carry on after that. So that's the first sign. There's also pain when you have intercourse. There's been more significant cases where the bowel and the bladder are involved. You can have endometriosis deposits in the bowel or in the bladder. So endometriosis, in terms of fertility, its major issue is what damage it can do to the fallopian tubes. That's the number one issue with endometriosis and fertility, that you can get blocked tubes or at least damaged tubes, leading to the inability of the sperm and the egg to get together. But it is more than that. There is reasonably good evidence that even when the fallopian tubes are clear, and even when the ovaries are clear, if there's endometriosis around, somehow the environment for implantation can be affected by the endometriosis. So when once we've taken a history, and what then happens if there's any thoughts about endometriosis, although probably nearly 20% of women who have endometriosis have no symptoms at all. So taking a history doesn't necessarily tell us that. So on every patient that I see with infertility, we also do a detailed ultrasound of the pelvis, transvaginal ultrasound, preferably done by sonographers who've been trained to look for endometriosis. There are specific signs in terms of thickening of the wall of the vagina, of nodules being visible behind the uterus, and of course in the ovary, the cysts that form called endometriomas are quite obvious. So having a detailed scan is a very important part of that initial workup in the attempt to exclude endometriosis as a possible reason why you're having trouble getting pregnant. If there is a suspicion of endometriosis, then it's probably worthwhile having a laparoscopy done. That's looking inside with a telescope under general anaesthetic as a day surgery procedure. And what can happen then is, first of all, you get the diagnosis right, because a lot of pelvic pain is not actually endometriosis. But secondly, if they do find endometriosis, removing the deposits can improve the symptoms and, more importantly, increase your chances of conceiving. So laparoscopy is the gold standard, although the ultrasound these days gives you a fairly strong indication. If someone's trying to get pregnant and they've got endometriosis, then many of the therapies that are now available in Australia are not recommended because they prevent ovulation. Because that's one way of resolving the symptoms of endometriosis, is not to have periods and, in fact, be menopausal. After the menopause, endometriosis pain disappears. But we don't want to produce a menopause in a woman that's trying to get pregnant, so that's not the way forward for fertility purposes.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.